Welcome to Thoracic Evidence Review. In this channel, we examine thoracic surgical practice through the lens of clinical evidence. For nearly 30 years, lobectomy has been considered the standard surgical treatment for early-stage non-small cell lung cancer. But in 2022, a large randomized trial published in The Lancet challenged that long-standing standard. Can removing less lung actually improve survival? Today, we review the JCOG0802 trial and examine its findings. A 30-year standard. In 1995, the Lung Cancer Study Group trial established lobectomy as the standard of care. Sublobar resection was associated with higher recurrence and worse survival. Over time, the principle became widely accepted. More resection means better survival. Why revisit this question? With widespread CT screening, smaller tumors are increasingly detected. There has been an increase in peripheral stage 1A cancers. As more early tumors are identified, interest in lung preservation has grown. The hypothesis of this study was that segmentectomy may preserve lung function without compromising overall survival. Target population. This trial included patients with clinical stage 1, a non-small cell lung cancer. Tumor size 2 centimeters or less. Peripheral tumor location. Consolidation to tumor ratio greater than 0.5. These were radiologically invasive tumors, not pure ground glass lesions. Study design. This was a multi-center, open-label, Phase 3 randomized controlled trial. It was conducted at 70 institutions in Japan. A total of 1,106 patients were randomized in a 1-to-1 ratio. Randomization and endpoints patients were assigned to lobectomy, 554 patients, or anatomical segmentectomy, 552 patients. The primary endpoint was overall survival. Secondary endpoints included relapse-free survival, local recurrence, and pulmonary function. Primary result: overall survival. After a median follow-up of 7.3 years, the 5-year overall survival rate was 94.3% in the segmentectomy group. In comparison, the rate was 91.1% in the lobectomy group. Primary result: overall survival. After a median follow-up of 7.3 years, the 5-year overall survival rate was 94.3% in the segmentectomy group. In comparison, the rate was 91.1% in the lobectomy group. Statistical significance. The hazard ratio was 0.663. The p-value was 0.0082. Segmentectomy was not only non-inferior, it was statistically superior. The survival benefit was consistent across predefined subgroups. Local recurrence was higher in the segmentectomy group, 10.5% compared to 5.4% in the lobectomy group, nearly double. Relapse-free survival. Despite this difference in local relapse, 5-year relapse-free survival was nearly identical. 88% in the segmentectomy group, 87.9% in the lobectomy group. Rescue treatment intensity. Among patients with recurrence, 93% in the segmentectomy group received intensive treatment. In the lobectomy group, 80% received intensive treatment. These treatments included reoperation, chemotherapy, or radiation therapy. The survival paradox. Segmentectomy showed higher local recurrence, yet overall survival was better. More deaths from other diseases occurred in the lobectomy group. These included second primary cancers, respiratory disease, and cerebrovascular disease. Physiological reserve hypothesis. Preserving lung parenchyma may help maintain pulmonary reserve. This may improve tolerance to future illness. It may reduce mortality from non-cancer causes. Lobectomy may be more physiologically invasive in the long term. Pulmonary function. At 1 year, the difference in FEV One was approximately plus 3.5% in the segmentectomy group. This difference was statistically significant. However, it did not reach the predefined 10% clinical threshold. The survival benefit exceeded the functional difference. Clinical implications for patients with clinical stage 1A disease, peripheral tumors, tumor size 2 centimeters or less, consolidation to tumor ratio greater than 0.5. Segmentectomy should be considered a standard procedure. Radical resection is not always better. Closing statement. This presentation summarizes the key findings. For a more detailed analysis, please refer to the original publication listed in the citation and review the full article.